Okay, so the following will be a video demonstration of the assessment of the cranial nerves. Now, presently you're seeing the equipment that is needed to complete this assessment. You'll need your common smell items, coffee and cinnamon, your ophthalmoscope, pen light, tongue blade and cotton ball, common taste, your salt and sugar, high frequency tuning fork, and of course another tongue depressor. So we'll do our cranial nerves. It's important when you're doing your documentation of the cranial nerves to indicate your findings using Roman numerals. So our first cranial nerve is cranial nerve 1, which is the olfactory nerve, which is testing your sense of smell. So what we'll need for this assessment is our coffee and our cinnamon. You want to be using common smells, something that a patient is familiar with, so we're picking coffee and cinnamon. You want to avoid using noxious scents to the nasal mucosa, like an alcohol swab. You wouldn't want to be using that. So this test is not routinely done. If you're doing a complete neurological assessment, you would. If the patient is coming in saying that they are having a hard time smelling things or they've had any type of head trauma, then you're going to proceed with this test. If they're in their room and they can smell breakfast coming down the hallway, then we know their sense of smell is intact. So just use your judgment in your assessment. So we're going to proceed with the test. You want to be sure your patient doesn't see the smells that you're going to be giving them to identify. And you have them close their eyes, and once their eyes are closed, you're going to block one nostril, have them sniff, just check for patency first, and once you've ensured that there's patency, you're going to take your odor and just simply wave it under their nostril and have them identify what the smell is. Okay, so we have 2 smells for them to identify. If someone has some nasal congestion, perhaps that sense of smell will be diminished. We become more concerned when there's the sense of smell is intact only on one side and not the other, which is why it's important to test the nasal sides separately and not together. Okay. So our next cranial nerve is the cranial nerve 2, which is the optic nerve, and we'll be doing 3 tests to check its integrity. We're checking visual acuity, we're checking with the fundoscope, we're doing some peripheral vision. So first of all, to test our visual acuity, we'll be using the Snellen chart. So you're going to give your patient a cue card, and the patient is going to stand 20 feet from the Snellen chart. Okay, so 20 feet is going to put your patient back over here, and so you make sure your 20 feet distance has been marked off the little piece of tape on the floor. So you're going to indicate to them to test each eye separately, thus you give them a cue card to block their line of view, and so you're going to test the eyes separately. If they use glasses for distance, they're going to keep their glasses on. We are screening here, we're not diagnosing. So if they use corrective lenses for distance, they're going to keep their glasses on. If, however, their glasses are reading glasses, they would take them off because that perhaps may blur their distance vision. So you're going to give them instructions to block their eye with the card and then proceed down the Snellen chart to the smallest line that they can read. Okay. You, as the examiner, are going to be at the Snellen chart. So when you're at the Snellen chart, you want to be sure to stand off to the side. You don't want to be doing this type of motion with your finger because you're partially blocking the letter, and from a distance it's going to blur what they're seeing. Stand off to the side, and you can have them start off at the big E and proceed down, or you could simply state, can you read the smallest line that you can read? And so once they say, well, I can read line 8, you have them proceed from left to right, and then switch to the other eye, have them block the other side, and have them read their smallest line again, but this time reading backwards. Okay, and that way we ensure that they haven't memorized the letters. Okay, so these will be our results. Your 20/20 is considered your normal Snellen chart results. If they happen to have 1 or 2 mistakes, you would subtract those from the denominator. So you would have, let's say, 2 mistakes on line 8 here. You may indicate it would be 20/20 with a small -2 to indicate your results. Okay. All right. So after the visual acuity, we're going to do the fundoscopic exam. Now, checking with the fundus is the back of the eye, and so we're now going to be using our ophthalmoscope. So you're going to connect up your ophthalmoscope, connecting the handle. You're going to attach the ophthalmoscope head, and then you're going to press the little red button or green button and turn the whole disc so that your light comes on. Okay. We want to make sure we have a small white light Okay, there are other apertures on here. There's a blue, there's a slit, there's a grid, large, and a medium, and a small. So you want that light to match as closely as possible to the size of their pupils. So if their pupils are small, go with the small light. If they've got quite large pupils, you're going to go with the bigger light. So ideally as close to that pupil size as possible. So once you've got your pupil size, you want to be sure to adjust your focus. So you're using your index finger here to adjust the diopters. So we're going to start off on 0. If I'm holding in my right hand for the right eye, I'm going to use my index finger to go up or down. And if I'm going in with my left, I'm going to use this index finger to adjust it down or up. Okay, start on 0, and you're going to come in, you're going to rest this strip on your eyebrow or forehead. You're going to position your hand on their forehead to give you some sense of where you are in space, and then you're going to shine the light through their pupil, proceed in through until you see the visual structures, adjusting your focus as needed. Okay, and then for your documentation for that piece, you'll document just what you're seeing. So if you're seeing vessels, great. If you see vessels in the optic disc, that's even better. And so you're going to describe the findings that you see when you look inside each of the eyes. Okay. The third and final piece for the optic nerve is the peripheral vision test. So for your peripheral vision test, you and your partner, your patient, will sit or stand across from each other. What's essential for this test is that you're sitting or standing at the same plane. So you don't want the patient sitting on the bed and you standing above them because your eye axes are not on the same level. So you really want them to be on the same level so you're truly getting a sense of their peripheral vision. So you're at the same level, you're fairly close to one another, about 1 to 2 feet, and then what you're going to do is block one eye with your hand. They're going to block their same side, and then you're going to bring in your wiggling fingers from 4 directions, from above, from below, from the temporal side, and the nasal side. And that way you're checking all of their peripheral vision. So when they block their one eye, you come up from above. This would be your superior. They indicate to you when they see the wiggling fingers. From below, inferior, bring in your wiggling fingers, they tell you when they see it. The covered side is considered the nasal side, so when do they see it? And the temporal, you're coming behind your patient, and so when they see it, that's when you would have that angle. So the normal angles are superior is 50 degrees, nasal is about 70 degrees, inferior is, this is 60 degrees, inferior is 70 degrees, and your temporal is 90 degrees. If you both have normal peripheral vision, you can record it as being same as examiners with a temporal of 90 degrees. You have to indicate the temporal field because it's not the same as yours because you can see it when they're coming in from when you're coming in from behind them. So those would be your vision, and then you switch and you go to the other side. Same idea: superior, inferior, nasal, and then temporal behind the patient. Okay. What's important with this test also is not only that you're at the same height, but you're actually looking into each other's eyes. So when you're coming with your wiggling fingers, the person needs to stay looking in your eye. You don't want them searching upwards because that's not a true test of peripheral vision if they're looking up to search for it. They need to look straight at you and maintain that eye axis, the parallel. The next cranial nerve is cranial nerve 3, which is the ocular motor nerve. And you'll see that as you proceed through your cranial nerves 3, 4, and 6 are testing the same pathways, and so the tests are done the same. So when you're doing testing of cranial nerve 3, you're also doing 4 and 6. So you're testing ocular motor, trochlear, and abducens at the same time. Okay, so 2 tests to test the integrity of these nerves. So the first is the 6 cardinal gaze. So for the 6 cardinal gaze, you're going to have your patient look at a point looking straight ahead, and you're either going to take the end of your finger, the end of your pen, or even just the end of your pen light, and you're going to move the object through the 6 fields of gaze. So when you're giving instructions to your patient, you're asking them to follow the object with just their eyes and not their whole head. So they're keeping their head straight, but following the object with just their eyes. So you start off in the center. You're about maybe 20 centimeters away. You don't want to be so close. That's the strain on the eyes. So about, 20, 25 centimeters away, and you're going to move through the 6 fields of gaze. That's called the 6 cardinal gaze. So you're going to start off and go to the upper quadrant, and then always come back to the center, out laterally, and back to the center, and down the lower quadrant, and back to the center. Same thing on the side. You don't want to be going too fast. You want to give the eyes time to adjust and to follow the object. And you're noting any nystagmus when they're following the object. Nystagmus is a very fine oscillation of the eye. At extreme lateral gaze, it's not uncommon, or it's fairly normal to see a little bit of nystagmus, but we don't want to be seeing nystagmus in any other area. If you note nystagmus, you would indicate in which field did you pick up the nystagmus. Okay? So that takes care of cranial nerves 3. Oh, sorry, no. We have another part. Sorry. We've got the direct consensual light reflex. So with our direct consensual light reflex, you're going to have the patient look at a point in the distance, and here we're looking at pupillary response. So when they look in the distance, this of course is going to dilate our pupils, and we're going to take our pen light now and we're going to shine it in from the side. And so when they look straight, sometimes people will put their bridge of their hand across the bridge of the nose just to block the pathway of light. If you're just coming in from the side and coming just the pupil and it's not reaching the other side, you know, that's okay, as long as the light doesn't reach both eyes, because we're looking at both a direct and a consensual response. So they look at the point in distance, you're going to put your hand across the bridge of the nose, you bring your pen light in, and you're watching the pupil response. You're expecting to see constriction with that light. Now this will be your direct response. On the other side, this pupil will also constrict, and that's your consensual response. It doesn't have the light, but it's actually also constricting. Okay, so this will be your direct and your consensual light response. And you switch and go the other side. Okay, they look straight ahead. You come in from the side, constrict this pupil for direct, and this one also constricts for consensual. And so when you're documenting that, you would document PERL, P-E-R-R-L. When we did the eye test earlier, we had PERLA, which was the accommodation piece. And so if we're just doing the light response, we would stop at PERL. Pupils are equal round, they react to light. For this particular test, we're not adding the accommodation, so you don't add in the A unless you actually do that part of the test. Okay. So then from those 3 nerves, 3, 4, and 6, we're going to go to cranial nerve 5, which is the trigeminal nerve. With the trigeminal nerve, there are actually 2 branches. There's a sensory branch and a motor branch. So with the motor branch, you're actually going to have the patient clench their teeth, and you're going to wrist the pads of your fingers just along the temporal and the masseter muscles, and you're going to have them clench. You're going to feel the constriction and then relax. So you're feeling the strength of that muscle contraction. So that's the motor branch. And you're looking to see if there's equally strong. Sometimes the textbooks will actually indicate for you to actually try to separate the lower jaw. You can do that if you want, but essentially we're looking to see that there's equal muscle strength. The sensory branch, we're looking at both a light and a deep sensation along 3 branches. We're looking at the ophthalmic, the maxillary, and the mandibular. Ophthalmic just above the eye, maxillary across the cheekbone, and then the mandibular just along the jaw. Okay, so we're going to do a couple of sensations. We're going to do the light touch, and so you're going to indicate to the patient to tell you what this feels like. Have them have their eyes open first. You say, this is what light feels like, so they know what to expect. Then they close their eyes and you touch them into these various branches. They close their eyes, say, okay, I feel it now, up here above my eye, here on my cheek, here on this side of my jaw. And so you proceed through those 6 areas to see if that light touch sensation is intact. That's how you would document it, that the light sensation is intact. Another sensation to test after your light touch is sharp. So what we do is take a simple tongue depressor, we crack it in half, so we have a dull for reference sake and a point for your sharp sensation. And again, you're going to tell the patient with their eyes open that this is what sharp feels like and this is what dull feels like, just so that they're not alarmed when you touch their face and their eyes are closed. So this is my dull, this is my sharp, I'm going to touch you over your face, and you tell me what you feel. So they're going to close their eyes and you proceed through again the ophthalmic, the maxillary, and the mandibular branches with both your dull and your sharp sensation. Okay, so this would be dull, sharp over here on my cheek, dull here on my jaw, sharp, and so on. So you're covering all branches. Okay. The last part of the trigeminal nerve is to do the corneal reflex. So the corneal reflex is not always done. If the rest of the cranial nerves seem to be intact and there's no concerns, we don't necessarily have to do the corneal reflex. If the person is wearing contact lenses, you wouldn't do this test. Because the contact lens sits on the corneal surface, you're not going to be able to elicit the response by touching with the wisp of cotton if there's a contact lens in your way. So you just basically take your wisp of cotton, you make a little fine wisp so that when you touch the cornea, what we're looking to see happen is a blink response. So the person is going to close their eye, or sorry, they're going to have their eyes open. You're going to tell them, just look straight ahead. You're going to come in from the side. You want to be sure you don't come straight in. If you come straight in, they're going to blink even before you get there, just a protective mechanism. So they look straight ahead. You're going to take that wisp of cotton, just come in from the side, tap the cornea, not the sclera, that's not going to do anything for you, the cornea, and when you tap the cornea, they should blink. Okay, and then you would do it on the other side, touch the cornea, and expect to see the blink reflex. And for your documentation, you would simply state that blink reflex intact or blinks bilaterally because you're testing both eyes. Okay? All right, so that brings us to cranial nerve 7. The next cranial nerve we're testing is cranial nerve 7, which is the facial nerve. And so the facial nerve also has 2 branches to test, both a motor branch and a sensory branch. The motor branch is simply observing the face at rest. During conversation, as you're doing your assessment, your health history, and you're talking to the patient, you're watching how their face is moving. And then you do specific changes, different facial expressions. All the while, in all these situations, you're observing for facial symmetry. So when the person smiles, and when they frown, and when they puff up their cheeks and you push them in, you're looking to see that there's symmetry here. So it's testing symmetrical facial movements. The second branch, the second test we'll do is for sensory, which is the taste sensation. So we're going to be using, again, common taste, so salt and sugar, and we're going to use a tongue depressor. Again, we don't want the patient to see what we're giving them to test, so we're going to have them close their eyes. I'm just going to put something on your tongue, and you tell me what you're tasting. So they close their eyes. You're going to take your tongue depressor and just going to open up your bottle. Take a little bit out. You don't need to take a whole lot out. Just enough so that they get the taste. And then their eyes are closed. You just drop it onto their tongue. And they tell you what it is. Salt. Okay. If there's anything left in your tongue depressor, don't put it back in the bottle. That's cross-contamination. Just tap that out. And then when you go to your second taste, use the other end of the tongue depressor or use a whole new tongue depressor. It's important not to double dip in the bottles. Again, it's a concern for cross-contamination. So if they're able to identify your salt and sugar, you can document it by saying that the taste sensation is intact or that they correctly identified common tastes like salt and sugar. So that's testing our motor branch and sensory branch of the facial nerve. Cranial nerve 8 is the acoustic nerve, so we're going to do a couple of hearing tests here. The first one is the whisper test. So with the whisper test, you tell the patient you're going to whisper a couple of words in their ear and they're going to correctly repeat it to you. So what you're going to do is come up to the patient, you want to block your mouth with your hand because if someone perhaps has difficulty hearing, they may be able to read your lips. So you want to block that with your hand. You're going to block the ear opposite to what you're testing. So if you're testing my ear over here, you just take your finger, just press on the tragus and block this side. You come over here about maybe 1 foot away, 2 feet away. You're going to block your mouth and you're going to whisper a 2-syllable word like baseball. So baseball, football, anything with 2 syllables, you're going to whisper it on the side that you're testing. And then the person should correctly repeat those whispered words. So they repeat back to you baseball or football. Okay, so just 1 or 2 words, 2-syllable, and if they're able to repeat those, then you would indicate that they correctly repeat whispered words bilaterally. So 2 ears, you do the test on both sides. Okay, so after we do our basic whisper test, we're going to do a couple of tuning fork tests. There's the Rene and the Weber. We're using a high-frequency tuning fork for these tests to check for hearing. So the first is the Rene, so we're going to take our tuning fork, hold it by the handle. You're going to ting your ends of the tines. You're going to give them a quick little snap and vibrate them. Once they're vibrating, you're going to put on the mastoid process. This is a timed test, and so it's important that you have your watch. You're not just guessing it. You should be timing how long they're hearing it from the bone, and we're comparing that to how long they hear through the air. And so in the end, we'll actually set up a ratio of AC to BC, or air conduction to bone conduction. So you tell your patient what you're going to be doing. You're putting this vibrating tuning fork behind their ear. When they stop hearing it, they're going to tell you, and then you quickly invert it in front of their ear, and then you continue timing. When they no longer hear it again here, then they're going to tell you, and that'll give you your 2 numbers. Okay, so vibrate the tuning fork, put it in the mastoid process, time it. So let's say they hear it for 10 seconds. Okay, after 10 seconds, they say, oh, I don't hear it anymore. Quickly invert it. Don't reting. Just quickly invert the time so they're here in the front, continue your timing, and perhaps they hear it for 20 seconds here. That gives you your ratio of AC to BC, which would be 20 to 10. Okay, so we actually flip our numbers, so we'll have a ratio of 20 to 10, which gives you a 2-to-1 ratio, which would be considered a positive Rene, which is what we would expect. We do expect them to hear better through the air than through the bone. So that's our Rene test. The next tuning fork test is the Weber test. So same idea, we're going to take a tuning fork, vibrate the tines, hold just the handle. Now with this we're checking for the conduction of the sound through bone, and are they hearing it equally on both sides, in both ears. So we vibrate the tuning forks, we're going to put it in the center of their head. This handle has to press onto their scalp, so they're actually getting the vibration through the skull. If it's just sitting up here in their hair, they're not going to hear it. If it's in a very noisy room, they may not be able to hear it. So this test, you may need to go into a quieter space if they're not hearing the vibrations clearly enough. So you vibrate it, put it in the top of their head, and ask them, where do you hear the sound? And you would expect your patient to indicate that they're hearing the sound equally in both ears. If perhaps there was a conductive loss or a sensory neural loss, they may say, well, I'm hearing it just on my left side, not really on my right. So then that would certainly necessitate further investigation. Okay, so that's going to be your Weber test. And then we have a couple of balance tests for the acoustic nerve. The first balance test is the tandem walk. So with the tandem walk, what we're doing here is we're looking to accentuate any problems with balance, and we do that by decreasing the base of support. And so the person's going to look straight ahead, and you're going to ask them to walk heel to toe. So it's important they're actually touching their heel to the previous toe. Hands just by their side, looking straight ahead, and walking heel to toe. What we're observing here is that they're able, first of all, to walk a straight line, and second of all, they're able to maintain their balance. Okay, so in terms of documentation, it would indicate maintains balance and walks straight line. The second balance test is the Romberg test. With the Romberg test, we have the patient stand with their feet together, their hands by their sides, and they just simply close their eyes. And they're going to close their eyes for 20 seconds, and you're observing to see if they sway or if they lose their balance. Okay. A slight sway is fairly common. If they do a little bit of a sway, that's not a problem. It's more of a concern if they fall or if they have to open their eyes and they move their feet. So we're looking to see that they maintain their balance for 20 seconds. And if they're able to do that, that will be a negative Romberg. Now, it's important for you as the nurse, as the examiner, to be there for safety. So when they're standing there with their eyes closed, you want to be right beside them with your arms, one arm in front, one arm in back, so that if they happen to lose their balance, you're there for a bit of support. Okay, so be sure to keep that in mind with Romberg, that you are there to maintain that safety. All right, so after the Romberg test, we're going to move on to cranial nerve 9, which is the glossopharyngeal. So with the glossopharyngeal, we're looking first of all at the position of the uvula and the palate. So you're going to take your pen light and you're going to take a look in their mouth. Okay, so they open nice and big. You look in their mouth and you're looking to see where's the uvula and where's the palate, and they should be in the midline. Okay. Then the next part of the glossopharyngeal is the taste in the posterior third of the tongue. This part of the assessment we were not able to complete. The pathway that innervates this posterior third for taste is technically too difficult for us to test. So it's like a bitter sensation. So in terms of your findings, if the rest of the tests we do for cranial nerve 9 are fine, then we're not really too concerned with this taste in the posterior third. So you would simply indicate on your lab sheets and your documentation that unable to test. Okay. And the final part of the glossopharyngeal is the gag reflex. So you're going to take your tongue depressor, and you kind of say this towards the end of your inspection and your assessment in the mouth. You're going to let them know, of course, that you're going to test their gag. You put the tongue depressor in. You're going to test, you're going to touch the back of the throat, the pharynx, the back of the tongue, and you're just going to give it a tap, and you would expect them to gag. And so you'd indicate gag reflex intact or positive gag reflex. Okay? All right, so now we're going to go on to cranial nerve 10. Now we've got cranial nerve 10, which is the vagus nerve, and you'll notice we're also still in the mouth. So the pathways of cranial nerve 9 and 10, the glossopharyngeal and vagus, they innervate the same pathways. So some of these tests we're doing are very similar. We're looking all the back of the throat. So the first part for the vagus nerve is to see their phonation. So as they're speaking to you, are they speaking very clearly. Sometimes there's some hoarseness to the throat. So we want to be concerned that, are they enunciating clearly? And you can gather, just as you're talking to them, collecting your health history, is their speech clear? The second part is the uvula and the soft palate. And so with the first part, with cranial nerve 9, we looked essentially at their position to see that it's midline. With cranial nerve 10, with the vagus, we're actually going to elicit a little bit of movement by having them say ah. So when they say ah, we've got our pen light, we're taking a look in there at our uvula and soft palate, and when they say ah, you see that the uvula and the soft palate rise in the midline. And so that's how we take it a step further from just cranial nerve 9. Here we're eliciting movement. So we're looking to see that they rise midline. And the final part of cranial nerve 10 is their ability to swallow. So, when you did your thyroid test, were they able to swallow? Are they able to swallow their own secretions? And if you want to test further, just give them a cup of water and have them swallow, and simply state able to swallow. All right, cranial nerve 11 is the spinal accessory. And this is a motor nerve. We're looking to do a couple of tests with movement. And the first one is to have them shrug their shoulders against your resistance. And so you come to your patient, you're going to press your hands on their shoulders, and you're going to press down. You say, I want you to push up against my shoulders, or against my hands with your shoulders. And so you're getting a sense of their strength there. Okay. So you could indicate, there's a couple of ways. If they're able to push up against your resistance, you could indicate equally strong, or you could use your muscle strength scale and indicate grade 5 bilaterally. So either one would be acceptable. The second motor branch for the spinal accessory is checking for the sternomastoid muscle. So we're going to be pressing against the side of their face. So you're going to say to your patient, I'm going to put my hand just against your cheek, and I want you to press against it. And then I want you to do the other side. My hand is on your cheek, push against it. And so you're really getting a sense of the strength there. Again, documenting, very similar to the first test, is equally strong, or use your scale and indicate grade 5, grade 4, whatever, bilaterally. Okay. And then our last nerve, the cranial nerve 12, is hypoglossal. If you break apart the word, glossal has to do all with the tongue, so we're going to be doing some tests with the tongue. So the first one is simply having them stick their tongue, and when they stick it out, they should be able to protrude in the midline. So when they stick their tongue out, does it come straight or does it deviate to the side? And that's one thing we observe sometimes in stroke patients, is that the tongue may deviate to one side or the other. So we're looking to see if there's a forward thrust midline. The second thing we're going to check for is just once the tongue is out, is to move it side to side. So once they've got the tongue out nice and straight, can they move it side to side? And we're looking to see that there's controlled movement. Okay. And the final part is to look at their pronunciation of R words. The movement of the tongue when they say particular R words is testing their lingual speech. So when they say rugged, ragged, reading, riding, railroad, those types of R words really look at movement of the tongue. And so you're looking to have clear, distinct lingual speech. Sometimes we use T words like light, tight, dynamite. Very similar idea. It all has to do with lingual speech and that it's clear and distinct to check the integrity of the hypoglossal nerve. And that concludes our cranial nerve discussion.